tremendous excitement about mitral valve repair here at the meeting, and so we're pleased to be joined by Dr. David Adams, who all of you know. David is a foremost mitral valve repair surgeon. David, thanks for joining me.
Thanks, Randy.
So the concept of and you talked yesterday and recently about the concept of a mitral valve repair reference center. What do you mean by that?
Randy, the points I tried to make yesterday were a reference center entails several things. It entails medical expertise, imaging expertise, and surgical expertise. You need all three, and a lot of data that you're aware of about patients not really getting guideline treatment or guideline referrals. So one of the points I think that reference centers need to emphasize is the timing of surgery. Patients that you elect to follow, you need to make sure that they have appropriate ventricular indices and function. If you're not sure, you should exercise them, a point you've often made in lectures. I think as surgeons, we have to have perfect imaging because we have the responsibility to say we can repair the valve or not. And we also always want to understand, does the valve dysfunction, does the abnormality in the valve warrant intervention at this time? Imaging also helps us control, because then our responsibility is to do perfect surgery. So a reference mitral center has to have the competence and expertise, and frankly the demonstrated expertise that patients are getting safe and effective surgery, that they're keeping their own valves, their morbidity is very low, and the mortality is extremely low. And
you've made the point many times, I think it's true, of follow-up. In other words, having, because you might get an echo before they go home, and then that's it. So does the reference center also follow those patients appropriately?
Randy, I agree. One of the problems in the literature is that for many patients, the intraoperative transesophageal echo after repair is the only echo they get.
Right.
You and I know that can't establish the baseline or whether a repair has really been successful. So it's really important in a reference center that you establish a baseline with a post-op echo done before the patient goes home, not on the operating room table. And then these patients ideally are followed serially by echo, because I always tell patients that the real success of a mitral valve repair is determined a decade later. It's really a decade of event-free survival, and that really can only be determined working in partnership with your cardiologist and making sure patients get serial echo follow-up.
David, and you've also emphasized not letting them leave the OR with any MR, basically, and that, I mean, that we've learned, haven't we?
You bet. That gets back to the imaging expertise, Randy. The valve repairs in the modern era, patients with degenerative disease, prolapse, they should never leave the hospital with mitral valve regurgitation. And if you read even current series, up to 10% do. And I think this really shows the difference between a reference center and a center that's trying to become a reference center. Reference centers have really no tolerance for residual mitral valve regurgitation. And I think that the other point I'll make, Randy, one you and I have talked about a lot, mitral valve repair can be a complex operation, and oftentimes other valves are involved. Patients need bypasses. You've got to have great intensive care. You cannot, these are different operations than isolated CABG or isolated aortic valve replacement. They take longer, and this is one of the only operations where the ventricle is asked to work harder at the beginning. When you replace an aortic valve for stenosis, it helps the ventricle. When you add new blood flow with a bypass, it helps the ventricle. When you reload the ventricle doing a mitral valve repair, you ask it to work harder. And that means that not just the surgeons, but the whole team taking care of patients, cardiologists and intensivists, have to be prepared for a few days, because some patients will give you a rocky course for a few days. And I think this is an important element of a reference center that we often don't put enough emphasis on.
That's a very good point. I mean, we've talked about it. I hadn't thought about it. David, the concept of a reference center also, you and Ani have looked at this spectrum of mitral valve disease. So is the reference center where the very complex valves should be done?
Randy, we wrote a paper a few years ago, and I'll stand by what I said. I think asymptomatic patients, young patients, and patients that have anterior bileaflet prolapse, these are the more complex groups for repair historically.
Right.
These are patients that should at least be offered a consultation in a reference center, in a high volume center that does mitral valve repair. I'm not advocating, and neither of us have ever advocated every patient has to go to one of 3 or 4 centers in a state for mitral valve surgery. That's not true. There are excellent mitral valve surgeons all over the United States. what we both feel strongly about, and I know you and I have talked about this a lot, is that every surgeon can't do a mitral valve repair just because it's fun. And a paper was just published 2 years ago by Steve Bowling. The average surgeon in the United States does 6 mitral valve repairs a year. That's not enough. And in each community, in each hospital, in each private practice setting, and in each university setting, surgeons should be identified that are interested in mitral valve repair, and they're the ones where those cases should be focused so that they can continue to work and get better experience and do better surgery for patients.
So you're talking about getting some of a surgeon locally who has an interest in valves, say, okay, you're going to do the valves, and we'll start with the P2s and you work your way up in complexity. Is that right?
I'm a firm believer that we can create local reference centers, but all for the most complex subgroups. For instance, a valve re-repair, a rheumatic repair. There are always going to be some cases, a severely calcified Barlow's, there's always going to be some cases that should go to really the highest volume centers. But if we do our job right in education the next 5 or 8 years, particularly with simulation and with sort of more advanced ways to teach surgeons, and I think we are winning the battle now with concentration of patients going to specific surgeons in specific regions. I think cardiologists are much more tuned in now that it's not just the doctor on call that does my mitral valve repair. The doctor on call can do my patient's coronary bypass, but my mitral valve repair patients, I think I have to know what their results are. And I think that over the next 6 or 8 years, we're going to see a significant change again in the amount of patients that receive valve repair because of better teaching and better education of cardiologists and higher expectations.
Absolutely. Two final questions. First question is, we're talking about tricuspid regurg, functional tricuspid secondary. Do you do tricuspid annuloplasty on this is degenerative MR patients on everybody?
We don't do it on everybody, Randy, but we have a low threshold to do it. This is a controversial area.
Very much so, yeah.
But to me, there's not that much controversy. All you have to do is operate on a few patients that had a successful mitral valve repair and now come back 5 or 8 years later and they're 75 or 80 and they have debilitating severe tricuspid regurgitation.
Absolutely.
And you'll want to do a lot more tricuspid valve repair. And one of the things that we've done is we've gotten much more sophisticated about it. We're not doing rigid rings, remodeling. We're doing very simple plications with either a special ring or a band or even a suture sometimes that's just preventing the dilatation of the valve, adding some protection in case in the long term the valve dilates. So what we do today is we do something very systematic. I look at almost every tricuspid valve. We compare it to sizers. If the valve's normal, we don't do it. And our threshold for tricuspid repair increases in patients that have severe LV dysfunction, pulmonary hypertension, or atrial fibrillation undergoing a MACE procedure. Those are really the 3 groups that we focus a lot on in terms of doing valve repair.
I mean, I think you're exactly, and when I said there's a controversy, I mean, it's not in my mind because I have seen patients that are 10 years out from excellent mitral valve repair and come in with neck veins up to here and florid TR, and they're a tough deal for you guys to go back and work on.
And Randy, you know, the other thing we've seen, you can say that the patients do well in centers that aren't aggressive about tricuspid repair, and certainly there are a lot of their patients do well. But I really believe that in the intraoperative course of many patients is simplified when you eliminate the transient tricuspid regurgitation they may develop when they develop transient right heart dysfunction. So and then again, if you have pulmonary hypertension or LV dysfunction on top of that, these patients are much more complicated. So I think that, you know, in the modern era of myocardial protection, and we've gotten much more sophisticated in terms of how we do tricuspid repair, it adds very little to the operation, honestly. And I think that the potential benefit, and it's going to take a randomized trial to really prove this, but the potential benefit for patients is that the virtual elimination of recurrent tricuspid regurgitation 5 or 10 or 8, 15 years later.
Super. Well, listen, you've done a great job in educating a lot of us and taking care of many, many patients. I appreciate you joining us.
Thanks, Randy, very much.
Good to see you.
Appreciate it.